cardiology practice. This is the list of these 10 trials which Dr. Deepak L. Bhatt, which is so well known to us cardiologists, and he keeps reviewing papers during the SC and the ACC, and this is his list and I'll go by it. The first one is the Paradise MI. Now, we've all been used to using ACE inhibitor, ramipril, post myocardial infarction with low ejection fraction and heart failure. And the question is whether that can be replaced in a better way by ARNI. This was a trial conducted which saw that there was no reduction in heart failure first events. The limit set was 15% advantage, but it could go only up to 10%, so the significance was not achieved. But the principal investigator said that the trial does show that ARNI could be a good replacement for ramipril if it is not better. But if you look at all the heart failure events, it does tend to reduce these events. The second trial was regarding heart failure, preserved ejection fraction, which has been amply discussed. And the two agents that are commonly used these days are ARNI and the SGLT2 inhibitors. We know very well that ARNI has been used and is useful in reduced ejection fraction, but what about preserved ejection fraction? We had the Paramount trial, which showed greater reduction with BNP. The Paragon, which did not show much benefit in terms of heart failure, hospitalizations, and deaths, but some kind of benefit came in the mid-range of heart failure. Then we had the Parallax trial with ARNI in heart failure, preserved ejection fraction, which showed some reduction in NT-proBNP vis-a-vis valsartan. And then we have the Emperor preserved. This is one trial which has shown clinical benefit, outcome benefits with the use of empagliflozin 10 milligram per day in patients with heart failure and preserved ejection fraction. And the primary endpoint, the time to first event, were all reduced, and so were the improvement in the renal functions. Then you have another SGLT2 inhibitor, the sotagliflozin, the SCORED and the SOLOIST trial. The SCORED trial showed that sotagliflozin shows benefit in terms of reduction of primary endpoints, and it went on to say that heart failure events were especially pronounced. The effect on heart failure endpoints was especially pronounced. And then you have another trial, the SOLOIST worsening heart failure trial, once again used sotagliflozin, and at 19 or 16 months of therapy, it showed a whopping 22 to 43% reduction in death or worsening. So SGLT2 inhibitors are showing benefit in terms of event reduction in patients with preserved ejection fraction going beyond what we have been used to seeing in reduced ejection fraction. And if we pool in the data from SCORED and SOLOIST, the impact on heart failure, preserved ejection fraction was very, very significant in terms of 33% reduction. And the maximum benefit came in the mid-range ejection fraction of 40 to 50%, and the benefit was startling. According to Dr. Deepak Bhatt, the benefit in terms of reduction of events is startling, and therefore he says that it is meritorious to give sotagliflozin and related gliflozins in patients with preserved heart failure because you want to reduce events. And this is what we have seen with Emperor preserved with empagliflozin. So gliflozins certainly are agents which have emerged as important drugs to prevent outcomes in terms of death as well as heart failure, hospitalization for patients with preserved ejection fraction. And then you have a Peru trial, use pirfenidone in heart failure preserved ejection fraction. Once is again being investigated to see the impact, and the impact was that it does help in terms of reduction of diastolic heart failure and improvement in clinical parameters in terms of 6-minute walk test, and even the quality of life tends to improve with this drug. But we'll need bigger trials to show the benefit of this drug. Now we have another group which is emerging. We know that you have reduced ejection fraction heart failure, preserved ejection fraction heart failure, then you have the mid-range ejection fraction heart failure, and now you have improved or recovered heart failure where you begin with 40% ejection fraction or less, and then with treatment it tends to improve and go above 40%. So what do you do with these patients? You should withdraw diuretics if the patient is asymptomatic. You can reduce the dose of beta blocker in these patients, but you should continue with RAS inhibition in MRAs, and you should do a regular follow-up with echocardiogram, 6-monthly clinical as well as echocardiographic evaluation, because these patients tend to bounce back, although they have a good prognosis in terms of reduction of heart failure hospitalizations, they have a lower mortality, and the 5-year survival is even better vis-a-vis patients who have reduced ejection. So any improvement with your trial, with your drugs, merits downgrading of treatment, but not inhibiting all treatment at all. And if the patient has been given an ICD, you should replace the pace set, the pulse generator when the time comes, because you never know, deterioration could occur further, and you could be using that ICD once again. CRT, of course, has been shown to benefit in patients with heart failure, but there are patients who will not respond to CRT, and therefore we now have started looking at his bundle optimized pacing, and which is found to be better vis-a-vis CRT, although there is no direct comparison with CRT, but a lot of QRS narrowing occurs. Ejection fraction improves in a very large patients. You have SIPA responders also, more than 50% improvement in ejection fraction with the use of his optimized pacing. But it's a difficult procedure to do because his bundle is a very small area. Pacing that area becomes a little difficult, and there are recurrences also. Therefore, you now have left bundle branch pacing or the left bundle area pacing, where the left bundle area is a larger area and pacing it is slightly easier, and the results are almost equally good as far as if you comparison with his pacing is concerned. A reduction in ejection fraction improves. Clinical improvement, it occurs in almost 80% of these patients, and there is a greater narrowing of the QRS. So now you are moving on from CRT to conduction system pacing, the his bundle pacing, and now the left bundle branch pacing. And you have these trials, the LOCRT and the HOCRT trials to show that. Then dual antiplatelet therapy has been alluded to a lot. The current recommendation is to use it for at least 12 after ACS. We are talking of ACS here. 12 months at least, but 12 months of dual platelet therapy can lead to increased bleeding, and bleeding can cause increased mortality. So the idea is to now reduce the duration of DAPT. Initially, you want to prevent thrombosis with a short-term DAPT, and subsequently over a longer period, you want to prevent bleeding by a single antiplatelet treatment. Now, single antiplatelet treatment, clopidogrel, in the stop diabetes trial was shown that it was causing more MIs, and it was certainly not working. So a single antiplatelet therapy after a month of DAPT was not working. So go beyond clopidogrel to a slightly more powerful agent such as ticagrelor, and this was certainly found to be useful in the global leaders in the twilight. And it was seen that if you give 3 months of therapy with dual antiplatelet therapy, ticagrelor and aspirin, and then switch to monotherapy with ticagrelor, you find that this is non-inferior to DAPT. Non-inferior in terms of prevention of thrombosis, and the bleeding risk was certainly less. So now we have a possibility of single antiplatelet therapy after a short period of dual antiplatelet therapy with ticagrelor. So the impression is that ticagrelor monotherapy may be the answer in most ACS patients. Clopidogrel monotherapy may not be useful, may cause more MI, but in certain cases it might be judicious to use clopidogrel as monotherapy, as was shown in the Masters DAP trial, where you have a high bleeding risk. So this looked at about 4,579 patients who had high bleeding risk, and after a month of DAPT, the aspirin was stopped and clopidogrel was continued to 11 months, and it was found that the primary outcomes did not differ between the two groups. So that means that in patients who have a high bleeding risk, single antiplatelet therapy after a month of dual antiplatelet therapy for another 11 months might be a good idea. Prasugrel also can be downgraded from 10 milligram to 5 milligram a day, as shown by the Polytech ACS trial. Now, there is a question of de-escalation. Suppose the patient has been on ticagrelor and aspirin, and you find that the patient is not tolerating ticagrelor, or the cost is too high, or there is some kind of bleeding risk. Can we go down to substituting it with clopidogrel? The answer came from Talos. You can do that. After a month of DAPT with ticagrelor and aspirin, these patients were switched over to aspirin plus clopidogrel, and that worked equally well, and there was reduced bleeding risk as well. Now, after you've completed dual antiplatelet therapy for about a year or say a year and a half, now what do? Do you want to continue with aspirin, or do you want to substitute with clopidogrel? So that is an answer that came from the host examination, which showed that once you have completed DAPT, After that, you could go to clopidogrel monotherapy vis-a-vis aspirin, and clopidogrel monotherapy over a longer period of time was found to be better in terms of reduction of events as well as reduction of bleeding. So now you have a choice that after you've completed DAPT, you can go to a single antiplatelet agent, clopidogrel. The limitations, according to the Americans, was it's a nation study, but it is not a limitation for us. And this host examination is being extended for another 10 years. And then we have the dual pathway inhibition, which we talked about a lot. The COMPASS and the Voyager trial, the ATLAS showed that if you combine aspirin with 2.5 milligram of rivaroxaban, the so-called vascular dose, it reduces events and prevents bleeding as well. Can you switch over after DAPT to DPI? That was the question that I was asking, that after you've completed DAPT, do you want to continue with DAPT as Dr. Pandey was saying, or do you want to switch over to DPI or the dual platelet inhibition? The answer will come from the SWAP AC trial, which is estimated to be completed by July of this year, and the results will be declared. What about DPI and SCAD? COMPASS has been amply discussed by Dr. Agarwal, and I think the time has arrived where for all multi-system atherosclerosis, we need to combine aspirin with ricosprin. The Voyager and the COMPASS have shown benefit. And whether this is going to be converted into clinical practice or not, we've read a lot about COMPASS, we've read a lot about Voyager PD, that peripheral arterial disease means that if atherosclerosis all over, you must give rivaroxaban in a sweet dose with aspirin for better results. But whether that is going to translate into clinical practice or not will come from the Zatova trial, which is enrolling patients at the present. Can I just take 2 more minutes? You know that revascularization in STEMI works. If you complete the revascularization after doing a PAMI to the infarct-related artery, you can tackle the other artery. And tackling the other artery, either in the hospital or subsequently, is going to improve results. But do you need to test the other vessels by FFR or not? Or you just eyeball it and you think that angiographically this lesion is significant, you will do it. Does it make a difference? This came from the Flower AMI trial, which is a recent trial. And it clearly showed that doing an FFR in the non-infarct-related artery to decide whether you want to do an angioplasty or not is not going to be very useful. Just looking at the artery and angiographically deciding that this is a vessel which needs angioplasty will work as well. So the time is now arriving where FFR is probably losing its steam, and the Ripcord trial also showed that if you do an angiogram and take a decision, you do an angiogram, then do an FFR and take a decision, doesn't change your decision, doesn't make any difference. So perhaps FFR in an acute MI situation or subsequently to assess lesions is probably losing steam. So with that, I think in the interest of time, I will stop here because the list is very long and we have little time, and we have now to go on to the other speaker also. So with that, I'll stop here and take questions if there are any.
Thank you, Dr. Narain, for presenting all